Thank you, Matthew. And the privilege is absolutely mine to have the opportunity of sharing this time with you over the next period. It's just a huge privilege and feels like both a wonderful thing and a very scary thing as well, because having 70 people in a room for 3 hours is a considerable investment, and so it is a huge privilege, and I'm really very grateful to Matthew and colleagues and also Health Education England for giving me that opportunity. It's always difficult to know where to begin, really, isn't it? I was Matthew and I were talking before we started this morning about some of the pressures that are on people who work within the health service. And I guess, thinking about what's it all about? All this National Health Service stuff, these regulators and secretaries of state and all these acronyms. And I think at core that what our health service in this country is about a national value of compassion. That by the choice that this country has made to have a national health service free at the point of delivery, no matter who you are, no matter what your wealth, no matter what your status in society, to say, we will provide care for those who need care. We will seek to enable people to be the best that they can be. And that is a national value. And the National Health Service is constantly in the papers. And when elections come along, it's constantly a theme because it is a national value. And that, it seems to me, that core value of compassion is what it's all about. And it's about, therefore, how can we create the conditions where we can provide high quality, continually improving and compassionate care to the people of the communities that we serve. And how can, when we think about the 1.4 million people, you included, who have made a decision in their precious, mysterious lives to say, we will dedicate 80,000 hours of our precious lives to caring for other people. That will be our vocation. That will be what we will focus our lives on doing. How can we create the conditions which best enable you and the rest of the 1.4 million people to deliver, to do what it is that you really want to do, what you came into this business to do? And that's, I think, what, in a sense, the challenge for us as leaders is all about. How do we create those conditions for the delivery of high quality and continually improving and compassionate care? How do we enable the people who work within the system to deliver that kind of care, to do what it is that they really came into this business to do? So that's what I thought I'd talk with you about. We have a discussion about today. Have you all come to the right meeting? And so in terms of, 3 hours, it would be indescribably painful for you if I stood here and talked for 3 hours. So I thought the how of what we would do is if I talk with you about what we know from the evidence and from research and from practice about what makes a difference in terms of creating that context, and to do that in some chunks, and then to have discussions around tables, and to share some of the reactions together in plenary. But also to ask you to make comments and to ask questions as we go through. Is that okay? Make sense? And we'll have a coffee break at 11:30. And as I don't have a watch, Matthew's going to rugby tackle me at some point and say, get out of the way, we're having coffee. So that'll happen at about 11:30. So when we talk about improvement initiatives and the work that you're involved in, actually some of the evidence we have is really clear that the context is all important. Whether you use a particular improvement approach like Six Sigma or Lean or whatever, it doesn't seem to matter terribly much, but the context matters an enormous amount within which you're trying to do the work that you're doing. So I think this issue of context, of how we create the conditions, is really, really vital. I think the most significant influence on the way that people behave within organizations, which are, after all, just communities of people, between organizations, which are different communities of people, the most significant influence on the way people behave, we've come to understand, is the culture of the organization. It's a kind of, it's a bit of a slippery word, culture, but you can say it means the way we do things around here. What are the norms? What are the values? It's the water we swim in. What are the unspoken assumptions about the way that we behave? So when I arrived at Huntingdon Station this morning, and I needed a taxi to get here, there was an orderly queue being formed. And I wouldn't even think of walking to the front of the queue because I was in a hurry. You wouldn't think of it. But in other circumstances, actually another example, it's really interesting because I'm in London a couple of days a week and I live in Sheffield, and last week I spent the week in the Isle of Arran in Scotland. And I noticed little things about the way people walk in London. So you're walking along and people just walk right in front of you, walk across you, and in Sheffield, where I live, it would never happen. People would not do that. Or if they did, it would be seen as incredibly rude or aggressive. And in the Isle of Arran, people just talk to each other when they pass each other in the street constantly, stop for conversations. So culture's the way we do things around here. And it influences our behavior to an enormous extent. We are constantly looking to understand what are the values, what are the norms, what are the way we do things around here, in order that we can fit in. Because being accepted, being part of the group, is so fundamental to us. So understanding the culture of our organizations and then seeking to influence them is really important. And I think it's really important, because if we want to create the conditions for high quality, continually improving and compassionate care, then it's about the culture. It's about the culture. And culture's not like a clock where you can take a bit of mechanism out and put it, you see what era of clocks I come from, but like the old mechanical clocks where you can take cogs out that aren't working and put another one back in. Culture is much more amorphous. It's more like a cloud. It's something that you're seeking to nurture, to shape, to send in the right direction. And the most significant influence, we've just finished a review of all of the literature on organizational cultures and climates, not just in healthcare, but all of the research on culture and climate. And what emerges from that review of research, particularly over the last 60 years, is the centrality of leadership to culture. That every interaction by every leader every day is influencing the culture of the organization. Of course, there are other factors like how we socialize people when they join our organizations, the induction process, the team they join. But the way leaders behave, what leaders pay attention to, what they focus on, what they model, what they reward, what they admonish, all of that is shaping the culture of the organization. So we as leaders, our every interaction, every day, is shaping the culture of the organization. So then the question is for us, okay, that feels like a huge responsibility, but also a huge opportunity. What then should we be focused on as leaders? What should we be concerned about? What should we be aware of every day in order that we can shape the culture, in order that we can create the conditions for delivering that high quality care? And what I want to suggest to you is that there are 6 key areas, and those are what I would like to explore with you today, and for us to explore together. But also to say that It seems critical to me in an industry that is concerned with evidence-based practice that we should adopt an evidence-based approach where we can to what we do in organizations. So when we deliver healthcare, we, as much as possible, rely on evidence to inform the interventions that we offer. It's not just, oh, I think this will work, it's my good idea. We use an evidence base, and in terms of the consistency of culture, given we have such an enormous evidence base around leadership and organization and teamwork and culture, it seems really important to me that we should draw on that evidence base wherever we can. Because, and I think this is important, because there is a lot said and offered about leadership and team working and culture and so on out there that doesn't come from an evidence base that you know, various consultancies may offer. But we've got a lot of evidence. Let's use it to inform the way that we design our organizations, the way we lead our organizations, the way we behave in teams. So I'm going to draw particularly on work in the National Health Service. So, for example, in 2003, I had the huge privilege of being involved in the design of the National Staff Survey, and then being involved in the delivery of it over an 8-year period. And that National Staff Survey, I think, is a real treasure of the system, because what it's enabled us to do is to look from the perspective of staff at how the service is changing over time. So, you know, for example, we see that the percentage of staff reporting that they have an appraisal has gone up over the last 12 years since the system was introduced, since the National Staff Survey was introduced, from about 61–62% up to the high 80% across the system, which is great. And we also see that the percentage of people reporting having had a useful appraisal conversation hasn't really shifted from about 38 to 39% over the course of that time. So, you know, I think there's cause for celebration in that more people are having that conversation, because I think it is important that we try to get total coverage, because we know that those conversations are really important in predicting levels of engagement of staff. But we also know that it's having the useful conversation which predicts levels of engagement, not whether you've had it or not. So what I think it gives us is cause for celebration, but also cause for saying we've got to redouble our efforts to make sure that we're not just introducing things in order to tick boxes, but we're introducing processes in order to help support people to deliver the care they want to deliver. And I could give lots of other examples of change that we see. The second thing that survey has enabled us to do is to look at differences between organizations. We can see how organizations change over time. We can see how the whole service changes over time. But we can also look at different organizations and say, well, who's doing things well? Do you know, I was looking at last night I was looking at the survey results for Barnet, Enfield and Haringey Mental Health Trust, and their percentage of effective appraisals is 10% above the national average. It's 49%, and they've got something like 95% coverage. Well, that's pretty good. It's not good enough by far, but it's pretty good. So we can look at places that are doing things well, and we can learn from them. And for me, the really beautiful thing about the National Staff Survey is that we can relate the results from the National Staff Survey to national outcome data like patient satisfaction, care quality commission indicators of care quality and financial performance. We can look at infection rates, we can look at mortality rates, we can look at absenteeism rates. So it enables us to really get a deep understanding about the factors that make a difference. And really, you know, as I've kind of indicated, a really powerful factor in the National Staff Survey predicting outcomes is the level of employee engagement within and across organizations. So that's a really great source of data for us, and I'll show you some of the results from that as we go through. The second source of data that's really important is, from my perspective, is that being involved in a 30-year now program of research looking at team working in health services, looking at what factors predict the effectiveness of healthcare teams in NHS organisations. And we began back in the 1980s looking at primary healthcare teams, and we extended that out to look at breast cancer care teams and community mental health teams, to the executive teams of NHS trusts, to frontline clinical teams across all sectors, to ambulance teams. And that's given us a real insight into the importance of both team working and inter-team working. And perhaps the most axiomatic finding to emerge from that work is the real importance of teams having a limited number of clear, shared, challenging objectives. Clear objectives, challenging objectives that everyone understands and agrees on at team level. And that they collect data that gives them information about good data that gives them information about how well they're doing in relation to those 5 or 6 or 7 objectives. And that finding has been so consistent across so many of the studies that we've done, of the thousands of teams that we've looked at in the health service. And also that one of those objectives should always be, one of those 5 or 6 objectives of every team should always be. Can you think what it might be? Somebody's whispering.
Improve how we work together as a team.
Improve how we work together as a team. Great idea.
Relationship, compassion.
Compassion, relationships, absolutely vital. But we say, from our work, from what we found, is that one of those objectives should always be improving the effectiveness with which we work with other teams within the system that we need to work with to ensure high quality patient care. Because inter-team working is as important as intra-team working in terms of the delivery of care. Please.
How do you judge that? Providing evidence that that's quite challenging. We obviously work on other teams.
Yeah. So the question, as I understood, was, but it's quite difficult to know whether we're doing that effectively. Is that the question? So when I said good data, I don't think it needs to be that sophisticated. So if this team here is working with this team, it seems to me what's good practice on a regular basis is to say, can you give us feedback on how cooperative we are, how helpful we are, how timely we are, what could we do to improve, what have we done that's improved, what's been the barrier, what's got in the way. Just checking it out with each other on a regular basis and coming together to have that meeting. So I don't think it needs to be a survey or, participant observation or whatever, just to take the time to gather the data to give us information about how we're doing, how to improve. Very helpful, thank you.
Yeah, that was like my review. My boss did the same sort of thing. The only thing was that she's carrying out the conversation with the commissioner to see that we're working well together.
Yeah.
And if there is any issues, that's when the mature company you talk back through. If something's raised, it needs to be discussed back through with you. You see the issue and the example. But it has been a challenge, but it has been useful. It's helped with me following up conversations with those commissioners on picking up on things.
Yeah. So it is challenging to have those conversations. Is that what you're saying?
Yeah.
But it can be really helpful. But it also manifests issues which are difficult to deal with at times.
Yes.
Yeah. And part of that, I think, is establishing with the other team, what's our shared purpose here? What's our shared purpose? Our shared purpose is ultimately, however it's phrased, prioritizing high quality, compassionate and continually improving patient care, service user care overall. That's what brings us together. I'll talk some more about this issue of how we work with how we work across boundaries as we go through. And the third study that it's a kind of program of research that we reported on actually just under 2 years ago now. It was a Department of Health Policy research program to look at the extent to which there are cultures of high quality care across the English National Health Service. It involved interviews with about 300 key stakeholders in the English NHS. It involved responses, 750 responses from patient and carer organisations. We surveyed 650 clinical teams across acute, mental health, ambulance, primary health care. The team spent 650 hours in ethnographic observations in A&E units, in intensive care units, in community mental health teams, in GP practice reception areas, watching, listening. What's the way they do things around here? How do they talk to each other? How do they talk about patients? How do they talk to patients? And we analysed the board meeting minutes of 70 trusts over an 18-month period of their meetings. What are they talking about? So that was our question. What are they talking about in these board meetings? 80,000 pages of the most exhilarating material you can possibly imagine. And what emerged from all of that work, there are many findings that emerged from the synthesis of that work. It was a very big and brilliant team that I had the privilege of working with. And what emerged from that was there are dark spots across the system, and there are light spots. And we can identify them. We know, which are the organizations where you wouldn't want people that you care for to be treated or mistreated or neglected. And there were places, and sometimes members of the team came back and they needed time to talk and weep because of what they'd seen. Often elderly patients are being neglected or not being cared for adequately. And they came back sometimes really inspired by what they'd seen. But even in the light spots, there were dark areas. And even within the worst organizations, there were bright spots of really compassionate care. So the challenge for us as leaders is how we can raise the level of illumination overall across the system and reduce the variability. Because every interaction by every leader every day shapes the culture, makes the difference to that level of illumination. So, and I've mentioned already that we've been conducting reviews. We also published in February a very big review of all of the leadership literature and the leadership development literature, not just in healthcare, but across sectors and internationally, but also with a particular focus on healthcare. So that's given us some really useful insights. And we've looked at particularly climate and culture in healthcare and what predicts excellence. So what I would like to do is move on now to talk about the kind of 6 messages that come from the work. Any questions before we do that?
Are those reviews available?
Yeah? So there will be links to them on the slides I show, so those links will enable you to download them, and none of them cost, so yeah.
Thank you.
How are you doing? So, in that case, let's begin. So there are 6 areas that emerge from the work. And we'll go through each of the 6 and pause from time to time. And I assume everybody will get copies of the slides.
They'll go on the microphone.
They're great, thank you. So the first is, and it kind of comes, it might sound a bit sort of, managerial and bit abstract. It's about there being a compelling strategic narrative in our organisations. So it's about the organisation, the community. Remember that an organisation is just a human community. Not just it. It's a human community. And so it's really important that we understand what the core purpose of this community is. What is it there to do? And what are its values, and what's the direction it's taking? Where is it headed in terms of what it's trying to achieve? So every organisation in the NHS has a vision and a set of values, and there's a whole industry around vision statements and value statements. When we looked at the board meeting minutes and analysed board meeting minutes, we found that very often there were boards that, in organisations that had a kind of vision around high quality, continually improving care. But when we analysed the board meeting minutes, we found that they were not discussing quality of care. They were not discussing continually improving care. They were talking about productivity issues, they were talking about the visits of regulators, they were talking about cost effectiveness, all important issues, but their stated purpose, the raison d'etre of the organisation, being about high quality, compassionate care, was not what they were talking about. And we found that where that discrepancy was large in terms of the core function of healthcare organisations and what the boards were talking about, in the National Staff Survey, staff in those organisations reported not feeling supported to deliver the quality of care they wanted to deliver, having lower levels of engagement and less trust in their leaders. And it's really, I think, fascinating how interconnected our communities are. So the board may think that what they talk about somehow doesn't directly affect the organisation implicitly or kind of unconsciously, but it's clear that what the board talk about and focus on permeates down. People become aware. It permeates through the organisation. Every interaction by every leader every day shapes the culture of the organisation. So the challenge for us is, as leaders, is to ensure that what we pay attention to, what we focus on, what we reward, what we talk about, what we inquire about, what we ask about, what we seek to support, is consistent with that core value or vision that we think is vital for the organisation. And the challenge is to ensure in our organisations that every leader is embodying that vision and that value, that set of values in the way they behave. Because then that communicates itself to everybody within that community and affects their behaviour, because we want to fit in with what the values are, what the norms are, and the way we do things around here. And that means all of us as well in terms of how we behave. So that's the first point. Any questions, comments? See, actually, while you think, this is important because on a cold, wet November morning, when a member of staff is making the decision to drag themselves out of bed and go and spend a really pressured, busy day, it makes an enormous difference if they feel that the values of their organisation, their community, are consistent with what it is they've committed their working lives to. That idealistic, optimistic, caring orientation, that compassion that motivates them. Where they feel there's that consistency, then they come with more commitment, more enthusiasm, more engagement. And where they feel that there isn't that consistency of values, then it undermines all of that stuff. So the way that we behave every day has a significant influence. Any comments or questions, please?
Can I ask a question about diversity? Because there's been, there's a lot of conversation about the value of diversity within organisations, do we progress change and in leadership?
I don't know if this works, but I think it would be really helpful if
There's a red button at the bottom.
red button at the bottom. I'll let you do it, Matthew, because
I think that.
yeah. Sorry to interrupt your question, but
I'll pass it around.
I just really wanted to ask a question about how diversity fits in with this agenda of creating this corporate vision and values, because there's been an awful lot of discussion about how diversity can progress change at more rapid pace, and we do need to embrace different ways of working, but how do you pull that back into a core or commonly held value? How the two don't always seem compatible. How do you align them?
what do you mean by diversity? What are we talking about?
Well,
Ethnic diversity, gender
No.
diversity, professional diversity?
diversity of approach, I suppose, really.
Diversity of approach, yeah. And so your question is, how do we integrate diversity of approach into having a clear vision or value
Yes.
in terms of direction?
Yes.
Yeah. So I'm going to talk about other aspects of diversity as we go through, particularly to do with ethnic diversity, gender diversity, sexual orientation, age diversity, and so on. But in general, what we know about diversity is when we have a really positive way of working, that diverse perspectives lead people to think more creatively. Actually, when we don't have good ways of working, diversity leads people to conflict and to be less effective and less productive and less innovative. But when we have really good ways of working, good team working, good inter-team working, then people benefit from the diversity of perspectives that offers when we listen to each other, when we're compassionate in the way we interact with each other as professionals. And through that, we can come to a shared vision that truly represents what we all believe in and value. Some of the problems arise when a limited number of people, specify what the value is or the vision is and tell everybody this is the vision. Well, it kind of totally misses the point in a sense. So really what we want to do is to, I think, through interaction and discussion and really listening to each other, is to sculpt visions and values that represent the core of what we're trying to achieve. And then they'll be much more influential and stable and profound.
Thank you.
If you hold on to it and then... Oh, sorry, Matthew, you want to... Yeah. Please, any questions? Please.
I'm kind of still forming the question, but it's around... Thank you. I'm kind of still forming the question, but it's around leadership beyond the NHS, so at government level, and how that impacts on the culture of the NHS, and how changing governments impact on the culture of the NHS, and how, as we know at the moment, there's lots of media attention on the NHS, particularly on failing hospitals, and again, how that affects the culture of the NHS. So we might wish to promote very positive cultures within our own organisations, but a lot of us here are struggling with funding of the NHS and the direction that the government seems to be taking it in.
Yeah. So everyone's clear about the question? When we look at the research evidence about hierarchies, if you have people who at the top of the hierarchy have a bullying style or a hectoring style or a very directive style, it's really interesting, the research shows, how that is replicated 4 or 5 levels down. So what seems to happen in communities is that where you have a bullying kind of style or a hectoring style or very controlling style. Almost unconsciously, leaders at lower levels replicate that further down, and so it flows down through the system. So there's no doubt that if you have government leaders, secretaries of state, cultures in overseeing organizations like CQC and Monitor, if those cultures are inconsistent with compassion, with listening, with empathy, that it will have an impact on the wider system. So that's really clear. It kind of feels really clear from the research evidence. And then the question is, well, what do we do about that? So there are those of us who seek to have those conversations. Matthew and I were talking just before we started this morning about the need to influence those organizations, and indeed we are working within them now. And they're beginning to work together over the last 2 years. They're beginning to start to talk to each other as well. But it's also important to do what we can, I think, despite that, within our own local area, because otherwise, we're just kind of giving up in a sense. And we do know that there are some organizations that have been really successful in creating very positive, very engaged, very compassionate cultures. And, what I say is let's beat a path to their doors to learn about what they've done to create the kind of cultures that they have. Places like, we were talking just before about East London Foundation Trust, a mental health trust, places like Northumbria. So there's something about taking responsibility at local level for bringing about change, for doing what we can. I've been, like all of us, have been really, I think, traumatized by what happened at the weekend in Paris. And I think that, I'm aware sometimes, some of the sensations that I've had are kind of almost like a hopelessness. What kind of a world have we created? But I think it's really important to say, well, actually, how we behave in our local interactions and with each other and with people who are different from us is really important in making a difference. And it's kind of empowering in a way. So I think the implication of your question is absolutely right. And I think it's really important that we also, while acting politically at a macro level, are also seeking at a local level through how we are as human beings to make a difference. So the second area is, again, it feels really kind of parochial, prosaic or something. It's not enough to just have grand visions and values. As we went round the NHS, what we saw was everywhere there were priorities being set. So to take your point, Secretary of State was setting priorities, CQC and Monitor were setting priorities, boards were setting priorities, directorates were setting priorities, and the people at the front line were overwhelmed with all of these priorities, all of this stuff raining down. We came to call them in the research team priority thickets. Cutting through the priority thickets. So there's something about translating what we're saying about visions and values and directions into a limited number of clear priorities. Over the last 70 years or so, the research on human motivation and performance at work has concluded that the most important influence on human motivation and performance is having a very limited number of clear, challenging objectives. People being really clear about what it is they're required to focus on. And we know that when people aren't, they're much more stressed. So the second point is really affirming that, and this begins with boards or the executive teams. They need to have 5 or 6 really clear objectives, because if they've got 40 or if they haven't got clear objectives, what we see is real consequences throughout the organization. And most of the executive teams that we have studied did not have clear objectives. Indeed, most of the healthcare teams we look at don't have clear objectives, despite that being such an important predictor. If the executive team hasn't got a set of clear shared objectives, they are working in silos, and that then is replicated throughout the organisation. And you get interdepartmental hostilities, lack of cooperation, people not prioritising patient care overall, but just prioritising the care in their individual area. Does that make sense? And we need then to make sure that there are those clear objectives at every level of the organisation and for every individual, so that they have that role clarity, which is likely to, which will help them be less stressed at work or more effective at work. And we need to make sure those objectives are clear. You're all familiar with the SMART acronym. What the research evidence shows is, yeah, that's quite useful, but what really predicts is having clear objectives, having challenging objectives. So the more challenging objectives are, the more motivated people are and the better they perform. But the caveat here is those objectives must be agreed. People are much more committed and engaged by a set of objectives when they've decided what they are, when they've agreed them. You know, and this issue of challenge is important. I hear people saying in the NHS at senior levels, why are we giving increments to people when they haven't achieved all of their objectives? This is a really silly question to ask, because if you implement that policy, the next time I'm asked to set my objectives, I'll make sure they're really low, the bar's really low, so I don't have to leap very high. Yet we know that there's an almost monotonic relationship between how challenging people's objectives are and their motivation and performance. But we also need to give, in order to encourage performance, teams and individuals good data that tells them how well they're functioning against those objectives. Ideally, on a day-by-day basis, not at the end of a year, on a day-by-day basis, ideally. And you know, there are organizations that are doing that. And what we saw across the NHS was an industry of data collection. Just the most amazing industry of data collection. We saw typically nurses at their stations in the acute sector entering the same data on 3 or 4 different forms, and the data never coming back to them to tell them how well they were doing in terms of their performance. This is just feeding the beast, to use that expression, and taking them away from patient care. And we know that the nursing staff, what they're really stressed by at the end of their working day is not that they haven't done their administrative tasks or completed them, it's that they haven't delivered the quality of care they wanted to deliver because they were so busy doing all this other stuff that seems meaningless. So there's, you know, it's really important we collect information, and that information should be about giving feedback to people who are delivering care about how well they're doing so that they can improve. So there's something both about challenging the collection of data and also the use that we make of data within the system. How are you doing? Any questions, comments? So let's take a pause, okay, to give you an opportunity to talk around your tables about taking these first 2 points. What are the implications for your collaborative? What are the implications for your organization? What are the implications for the wider system that you work in? Because I know that there are people here working across boundaries. So have an exploratory discussion. And if we take 10 or 15 minutes for that, how would that be? Okay? Great. So forgive me for interrupting the conversations. Can I suggest what would be maybe helpful is for each table just to tell the collective here, everybody, what's the kind of one key point in a way, or 2 key points that have emerged in your discussion that would be helpful to share with everyone else. So if we begin with the table over here, and then we can pass the microphone from one to the other.
Okay, one key point I think that we come up with quite quickly was that possibly our goals that are still in an early stage in terms of setting, particularly from the webinar and what we've discussed today, it's come quite clear that they're fairly process and solution focused as opposed to sort of thinking more globally around what are the outcomes that we're looking to achieve. So I think certainly from our table's perspective this afternoon, we're going to go back, sort of reflect, look at our aims and our goals and perhaps reset going forwards. That was the key thing for us.
Thank you. Do you want to pass the microphone over to the next table?
Well, I think our conversation sort of focused on achieving and measuring clear objectives and goals. And I think generally we thought goals and objectives and measures of those were a good thing. What we were discussing was the need for the interpretation and the measures to be intelligent, you know, picking up on your example of the appraisals and PDPs. And we had various examples, you know, good and bad, but it seemed to be this intelligent interpretation that the non-achievement of targets doesn't become a punitive tool, but continues to be an intelligent tool that you can use to create improvement. And I guess our discussions seem to indicate that's very much a work in progress, but certainly something that we kind of need to address in the NHS and kind of make that connection real between what boards are establishing as measurable targets and how that connects with the people on the ground delivering the care.
It sounds like there's a real need to have dialogue. You know, that you don't just find these intelligent measures and intelligent objectives. You know, somebody sits in a darkened room. The need for dialogue to achieve an understanding of what's going to be intelligent and helpful.
I think also something that came out was the kind of, the skills of managers. It varies, really. And some people can do this very, very well. Some are less experienced. And they say, well, all that has an impact.
Absolutely. Thank you. We'll come back, and I'll come back to that point. It's a really key one. Can you pass the microphone, please?
So we had a conversation, I think, about trying to discern clarity in a really, really complex world where many of us from different organisations. And we think that there are common themes. We think that we can pick out common objectives from the different organisations that we work with, and that there's a movement towards that. But actually it's still really difficult to pick some of that out and then to define our objectives as a cross-system collaborative in relation to that ever-moving playing field that we're on is really difficult, and I think that's something that we're struggling with. And I think that there's also some really important insights about the importance of challenging goals and measurable goals, and we're reflecting a bit about that and about what that means within our individual organisations.
It's really helpful. Thank you. I think the objective setting process or agreeing process is not easy. And if it is easy, it suggests people aren't thinking carefully enough. Yeah. Thank you.
Okay, so one of the things that we really reflected on was that the goals that we've set are very negative. So it's all about reducing. It's all about, and again, linking in with the kind of the process-driven element of the goals as well. And I suppose we were saying that, you know, how motivating is that for the workforce if we're all about reducing the cost and reducing duplication? And so I think that I suppose, reflected that we needed to take a look at the goals again and think about how we could set them in a more positive light. So the reason that we're wanting to reduce duplication is because we want patients to only have to tell their story once, to see one professional. And so it's about the way that you tell that story and connect in with the workforce who we want to be going out there and doing some of it. And one of the other things that we reflected on right at the end was about culture, because someone said, oh, well, is the culture of the two organisations we've got here, is it quite different? So we're about integrating health and social care. And actually, we were reflecting that it is really very different, the culture that we've got within those two organisations, and we were starting to unpick some of that.
Fascinating, really helpful. I always think about culture because I've had the privilege of going to lots of different organisations, not just in healthcare, but in other industries, manufacturing, oil and gas. Actually, I started my working life I worked underground for a year in South Wales. You're all too young to know what a coal mine is, but anyway. Do you know, and actually, whenever you go into an organisation, any kind of organisation, if you want to be a student of culture, from the very beginning, you are discovering the culture of the organisation. You know, in the reception area, the plant's dying. What are the notices that you see? In my GP practices, there are all of these, as you describe them, negative notices everywhere. You'll be in trouble if you do this. Don't do this. Do you know? So the culture is, we can be students of culture. Really helpful observations. Thank you.
We'd like to second that, because we're going one step even simpler than that when we were discussing that we are within one hospital, so our culture and our divides and our objectives are within each other. So we're looking as basic as the managers and the consultants and the doctors and things like that, about how we can get the challenging but in a positive way between them understanding the best for the patient and what the doctors and clinicians want to do, and the managers who are always saying cost improvement, you can't have this, you can't have that. So we've got to think a bit more simpler and start really from the basics and get our own cultures within our hospital on board with each other first before we can even start to make progress.
So you have these subcultures, the way clinicians, the values that clinicians have and the values that managers
all right.
have.
They're all good.
Yeah, but they're different.
But they're different.
Yeah.
So we've got to sort of get some of that across, because even like with managers, we want to do the same, but we have more of a financial, you know, the more of that sort of level within us. So we've got to somehow get the two joined up and understanding each other.
And I think that goes back to your question about diversity. That there are these diverse values and diverse views. In the work that we did in that big multi-dimensional study that I described, probably the most basic conclusion we came to about this sector called the NHS was just the huge need for dialogue, that people weren't talking to each other. Boards would tell us what the problems were. It's the nurses at the front line. And the nurses would say there aren't enough staff, and there's chronic conflict with radiology. Who knows who's right? But they weren't talking to each other about achieving a shared understanding of what the issues were as a basis for finding shared understanding how to go forward.
That's what we would like to do, and I think the table here that have just spoken actually said it completely right. We've got to be within ourselves first before we can move forward.
Yeah.
We've got to be joined up.
Helpful, thank you. You want to?
Oh, sorry. Oh, sorry. That's okay. On our table, we actually were talking about some of this sort of conflict.
Can you hear?
Sorry.
No, if you
on our table,
think Beyonce.
Sorry. Don't do it. Just get up now. We were talking about, I think, about leaders' behaviors, how they impact the organization, how everything we say, do, or even some subtle sort of behaviors can be interpreted by the staff, by the teams on what your focus is. And also, we were talking about some of this language, about focus on the metrics, a lot of performance sort of is very much number based. So I think some of the other tables mentioned about reduce this or cut the cost. So whereas actually reducing some of that means actually less errors or less handoffs for patient, but we probably putting our focus on the slightly different aspect to what the clinical teams at the coalface think their business is, and then you get this misalignment. And we also talked about some of our leaders, especially at the senior teams, who are sort of looking at sort of maybe their short term, their next job or their next portfolio of career move that they are planning. And so you get a lot of these different senior members coming in who have a clear agenda or view about how they want the organizations to proceed. They have different ways of working with the stakeholder organizations, and that can then create a ripple effect down the line, which can at times be quite negative.
And so what I can hit something in what you're saying about it being destabilizing because of these constant changes and
yes,
directional changes. And
yes, the organization I come from has gone through a fairly rough patch, and it has actually caused us a lot of problems with recruitment, retention of staff, and sort of having that clear objective or idea of where we are going.
Yeah, and sustaining it.
Yeah.
Yeah, thank you.
Yeah, we had quite a straightforward conversation, actually. We're Children and Young People Services, and we're looking at sort of greater integration, and we just kind of looked at it quite simply and kind of agreed that we didn't quite have our vision right, and probably our goals are not quite clear enough, particularly for the broad range of stakeholders, from a young person to a commissioner. And actually, we probably need to go back, I think, and we've done a little bit of work in our impact group, but some further work of actually trying to really distill those down further. We've got a session coming up with some parents, and we're just thinking about how we can use this to have a conversation with parents about how they'd like to see children and young people's health services in the future.
And what they think your objectives should be.
Yes.
Yeah. So getting their input to your objectives might be really powerful. Yeah. Brilliant, thank you. This table, I think.
We had two approaches. We took a macro, first of all, in terms of our experience on objective setting across organisations, and then we moved on to a little bit around our collaborative. At the macro level, we had sort of two main themes with some of us have experienced got fairly strong objective setting for our own organisations, but in the political landscape that we work in, how those objectives can be interfered with by outside forces, if you like, and that presents a challenge because if you're not careful, you'll. I've had some acute experience in the past, and I can remember senior executives wandering the corridor because the latest initiatives arrived, and suddenly it torpedoes everything you're working on. Then you're expected to be on, just respond. And if you're not careful, your set objectives that are so high level, they're vague, and are they robust, and so on. And so it's just recognising that. I think there are techniques and approaches you can use, but I think recognising that is quite liberating. The fact that you have to be flexible and respond. We also
kind of echoes the point that your colleagues on the table behind were making about the difficulty of setting really helpful, clear objectives and the need for dialogue to get, and then to have intelligent data that tells you how you're doing against them.
Yeah, and it's actually energy sapping to do it and to keep on top of that, to keep up to date, and it does bring in the integrity to keep true to where you're working to with that context you're working to is quite hard. And picking up again what Archie's saying in terms of individuals who might have a different agenda. Yeah. But in terms of I think there's more around satisficing objectives, and it gets watered down if you're not careful. From our collaborative point of view, we think we can definitely see where we've come a long way in terms of we're recognising, reflecting on culture, and that we are very similar. We're in different organisations, but we have got some really core, strong values. And that's probably a session that we had on the residential, where we went through a real storming, forming, norming, and we went on a journey, X Factor, but we did. But we've come out of that on a strong basis to work on, but we're also not smug, because I think we've recognised that there's some gaps similar to the last table where we need just to further strengthen that, which can be a bit of challenge from our colleagues and our sponsor organisations, because they might say, are you just talking about what you might do together all the time? But I think the speed of the journey that we're on in terms of the conversations we're having has to be built on a strong foundation. So I think that's one of the privileges that we have from being involved in this process. We're given the time to have those discussions.
So there's maybe something about the other collaboratives learning from what you've gone through. Be quite useful maybe for them to have a conversation with you.
I wouldn't be so bold in terms of and I've had a lift conversation with colleagues in my own organisation, and there's a different maturity about what we're trying to do in terms of work together and in collaboration, and that sort of penny dropped with me over a series of time from the several sessions. If we wanted to go simple gap analysis and we're here and being mechanistic, it wouldn't tick the box of a lot of the skill sets that we'll all have, because it's much more qualitative, it's not so quantitative. Now, and we can have a great debate on that, and that gets me, that's like a pub conversation for me now, but I've become really boring to friends at football and stuff like that. And I said, what did you do? Because it's a different sort of way of seeing things, and I'm from a data background looking for facts and figures, and I'm picking up on more qualitative data now. So it's had an impact. On the collaborative level, though, we recognise there's some gaps in what we're doing, and that we need to build on those.
Thank you.
On this table, we had some really useful discussions around how we felt that the vision or values should inform the overall culture of the organisation, but how, in real terms, there are multiple very strong cultures within NHS hospital working, ambulance trusts and community. And really came back yet again to the point that you need to create that dialogue and the communication to spread the light and to try and keep these good pockets of work and new ways of working perpetuating. So that was one theme that we talked about. And then the other theme that we moved forward to was looking at the vision as an aspiration for the organisation, in that sometimes when the vision is so beyond the reality of the work, how you lose the hearts and the minds of the workforce. And it was really about trying to keep the aspiration there, but not dropping off the end of the curve, if you like, in performance.
And I think there's something, it goes back to your point about managers having the skills, that one of the things that we see across NHS organisations is a great deal of variability in the quality of leadership and in the styles of leadership. So you have some leaders who are very facilitative and supportive and enabling and empowering and engaging, and some who frankly are bullies. And as a consequence, you get a huge variation in subcultures within an organisation. And that's problematic, because it becomes more and more confusing to know what's the way we do things around here. Okay, there's a vision statement, but actually what I see on the ground is highly variable. So that's an issue we'll come back to. So thank you for those comments. I don't know about you all, but I found them absolutely really thoughtful and helpful and fascinating. And I think we should take a break for coffee. I'd like some coffee anyway. 15 minutes? Thank you. You know, when I don't know about you, but when I feel poorly, I just want to be quiet somewhere. You know, if I'm feeling ill, I just want to be quiet. I want to be peaceful. I want to feel safe. I want to be able just to be still, not to have to respond. And what has always... I think what really struck me and the rest of the team who were visiting healthcare organizations around the country was when you were in these organizations, just how frenetic they were, how noisy they were, how frantic they were, how it was very difficult for people to be present with each other. It was very difficult for people just to be present. It was always, there was a kind of sense of, okay, I'm having this interaction with you and I need to go on to the next thing, and it was just, you know, that sense of presence, of being here with you now, paying attention. So, and if we take the concept of compassion, so a way of understanding compassion that I find really helpful from the research literature on compassion is it kind of has been broken down into, if you like, 4 components. So if I'm here with you and I see you are in, I have the sense you're in distress, you know, you look distressed. So compassion is, first of all, it's about being, the first component of compassion is being present with you, paying attention. And there's a lovely phrase, listening with fascination to what you're telling me. And then the second component is, I need to make some appraisal of your distress. What is it? Where's this coming from? What's the cause of it? And ideally, you and I will do that together, if you're able to. Or I have to make, as a professional, let's say, I have to make some appraisal of the situation. And the third component is having an empathic response. So it's feeling, and we are designed as a species, we're really incredibly hardwired to be empathic. And then the fourth is to take intelligent action to help. Make sense? So, but the first is about being present, is about paying attention. And the challenge for us, I think, as individuals, is to learn to be present, is to have presence, to learn to be present. And you'll be aware, no doubt all of you are familiar with the concept of mindfulness as a practice, which is kind of, I suppose, become really part of mainstream thinking now. I mean, it comes from traditions that are thousands of years old. But basically, mindfulness is about, it's the idea that we are present in the moment, that we are open to experience, and that we view our experiences in a non-judgmental, accepting way. So instead of the kind of constant chatter of judgment and reaction and whatever, we learn simply to be present. I'd like to invite you just for a few minutes, before we begin the next session, just to have a 2 or 3 minute mindfulness session, if you'd like to. And if you don't like to, then just sit comfortably and chill out. Is that all right? So, what I'd like to invite you to do is to sit comfortably in your chair, but upright, feet on the floor, and your hands resting wherever's comfortable. And if you feel comfortable, then I would like to invite you to close your eyes. Stillness, quiet, peace. Just be aware of this stillness. And let your attention go to your body. And just allow your body to relax. No trying, no forcing. Just simply allow your body to relax. Feet letting go of any tightness or tension. Calf muscles, the upper part of your legs, letting go of any tightness or tension. Pelvic area, lower part of your back. Warm, comfortable feeling of relaxation spreading up across your body, lower part of your back, the upper part of your back. Stomach and chest area relaxed. And let your attention go to your fingers and your hands, and if they're tight and tense, just allow them to lie comfortably and relaxed. Maybe a sensation of warmth in the palms of your hands as they relax. The forearms and upper arms relaxed. Warm, comfortable feeling of relaxation spreading up to your shoulders and neck. And your jaw and your mouth and lips. And if your teeth are tightly clenched, just allow your jaw, your mouth and lips to relax. And that warm feeling of relaxation spreading up across your cheeks to your eyes. Light, comfortable feeling of relaxation. And your forehead relaxed, maybe a sensation of warmth in the center of your forehead as you allow the relaxation to spread up across your body to your face and your head and across the rest of your head and scalp. So just being aware of your whole body, warm, comfortable feeling of relaxation. Just enjoy that sensation of stillness for a moment or two. Now let your attention go to your breathing. Just let your attention dwell on your breathing. Might be as your stomach rises and falls, or your chest rises and falls, or sensation in your nostrils, or at the point where the breath enters and leaves the nostrils. It doesn't matter where. Just let your attention dwell on your breathing, feeling the in-breath, the point of balance between the in-breath and the out-breath, the out-breath, the point of balance between the out-breath and the in-breath, like waves on the shore. Very easy, comfortable process. Openness and contentment. Openness and contentment. Quietly watching your breathing. From time to time, there may be thoughts that come along. And you just treat these thoughts as you would treat clouds drifting across the sky. You don't hold on to them, and you don't push them away either. You just watch them come and go. And then when you feel ready, you very gently bring your attention back to your breathing. openness and contentment. And now gently let go of watching your breathing. Bring your attention back to your body, being aware of the sensation of your hands, your feet, the sounds around in the room. And then when you're ready, just very gently, very slowly, open your eyes, bit by tiny bit, and come back to being here in the room. Everybody here? Yeah. How was that? Was that easy? So it's about practicing being present. It's like any skill. It's about learning and practicing being present, but doing so in an open and contented way. Not trying, not forcing, in an open and contented way. And you can practice in meetings, in interaction with another person, in the corridors, in interactions with service users and patients, learning to be present in the moment. But it's practice, practice. Shall we move on? Thank you. So, the third point I can sum up by saying, if we want staff to treat patients with care and respect and compassion and dignity, we have to treat staff with care and respect and compassion and dignity. So if we look in the National Staff Survey data, what we see over the 12 years of the analysis that we've been doing, so we can look at how changes in staff experience predict changes in outcomes, we see that levels of staff satisfaction predict levels of patient satisfaction. So staff views of their leaders predict what patients say about the care that they receive. When staff report high levels of work pressure, patients say that they're not given the respect and the care and the dignity they want. They don't see enough staff to look after them. And what we know about compassion is that if people are under high levels of stress, in other words, if they have very high demands but low control over those demands and low levels of support, then they are less able to be present and to listen with fascination. They are less able to make intelligent appraisals. They are less able to be empathic, to feel what the other is feeling, because they're so busy dealing with their own emotional anxiety, their anger, their frustration, their fear. And they're less able to come to think about intelligently, how can I help you with your distress? So I think that one of the most disturbing, taken for granted assumptions in the NHS as a sector is the assumption that stress goes with the territory. So in the early 1997, we published a paper which was focused on stress levels in the NHS. And it was a very big study of 10,000 NHS staff. We also did 600 clinical interviews with staff to establish what was an appropriate kind of cut-off point that would say above this level, staff have such significant levels of stress that they are indications of psychiatric morbidity. Make sense? 28% of staff scored above that cut-off point, compared with 17.8% in the general working population. So a full 10% more staff, more than 1 in 4 staff in the NHS, had levels of stress indicating psychiatric morbidity, that they needed professional help, really. That situation, I don't think, has changed in the intervening 18 years. So if we look at levels of stress reported in the National Staff Survey, 40% of staff are reporting that they've experienced significant stress at work in the last 12 months. NHS staff are consistently top of the Health and Safety Executive League of staff stress levels across industries in the UK. But we've kind of somehow come to accept that that's the territory. It does seem to me scandalous that we are killing people in the process of delivering care. We're killing staff in the process of delivering care. We know that chronic stress predicts heart disease, it predicts all sorts of negative health outcomes, it predicts damaged family relationships, it predicts mental health problems, of course. We're creating customers for the NHS through the way we manage staff in the system. It just is such a paradox. I actually feel really angry about it, because it's been kind of almost taken for granted. That's the way it is. And organizations are not really taking the steps needed to bring about change. Finance directors 2 weeks ago, in their kind of State of the Nation national report, said their greatest concern was levels of staff morale and staff stress in their organization. Let me not disrespect finance directors, but even finance directors are saying this, you know? Whose orientation is, much more to other things. That's their job, but they perceive what a problem this is. And it directly impacts care. So we know that poor staff health and well-being is associated with poorer quality care. CQC ratings, poorer quality care. Higher levels of stress in organizations, lower quality care. Worse financial performance in such organizations. And higher injury rates among staff. So it does seem to me absolutely vital that we address this area. And actually what I think it's about is that when we think about compassion, and we talk about compassionate care, and compassion being a core value, that it's really important to understand that culture is not about slices of pizza. So we can't say, well, we want our staff to be compassionate towards patients, but the way we're going to manage our staff is kind of directive and target-driven. One of your colleagues came up to me in the break and said no one had put their arms around people in these beleaguered staff groups for 2 years to say, you know what, you're doing a really good job. That nobody was doing that for them, who were under such huge pressure. If we don't have a consistency of culture, then we can't create cultures of compassion. We've been doing some work recently looking at levels of compassion in NHS organizations and asking staff, and they say really high levels of compassion from staff to patients. Actually, it's pretty good between colleagues, but the level of compassion shown by leaders and managers is really remarkably low in the data that we've got. So I think it's really important, if we want to have cultures of compassion, then we need to have compassionate leadership. High quality, continually improving, compassionate leadership. Leaders who pay attention to those they lead, who listen with fascination to those they lead, who with them make an intelligent appraisal of their situation, who are empathic in their response to staff, and who then work with them to take intelligent action to help. Now, I think it's, as a model of leadership in the NHS, that's what we need to develop. Continually improving high quality, compassionate leadership, paying attention, intelligent appraisals, empathic, taking intelligent action to help and support. Because that's how we create cultures of compassion. And it goes back, to the point you're making about consistency of cultures that have the same values within and across organizations. And I've talked already a little bit about HRM practices like appraisals. The most important predictor, as I've said in the National Staff Survey, of outcomes across ambulance trusts, community trusts, mental health trusts, and primary care, is the level of staff engagement. And it's this is a really interesting concept. And it's people talk about it, it's a bit like culture or compassion. Well, yeah, but what does it mean? Engagement, what does that mean? The guy who developed the idea, Daniel Kahn in the 1990s, talked about engagement. He said, imagine an actor coming to perform on the stage on a Saturday night. Engagement is the extent to which she brings of her emotional intelligence, her humanity, her life experience, her courage to the role, to perform in it. That's what engagement is. That's what it means. So when we talk about staff engagement, it's the extent to which it's asking staff to bring of themselves, their emotional intelligence, their compassion, their commitment, their life experience to the role that they're performing. Why would they do that? They would do it if they felt really high levels of trust in their leaders, if they felt a sense of support, of being cared for, of being nurtured. So it I have this sense the word engagement is bandied about as something that, we've got to make staff feel as though it's you just push a bunch of levers and then staff will feel engaged. It's about the kind of emotional environment we create, the kind of nurturing we create, the kind of culture we create, in effect. So we did some work last year to look at what were the characteristics of those organizations that had achieved and sustained high levels of engagement. And the first is a factor that we've talked about already, which is this notion of a compelling strategic narrative, a clear narrative about purpose and aims. This is an organization which has had the same statement driving its culture for the last 150 years. It has virtually the highest levels of engagement of any retail organization in the country. Now you know what it is. It's John Lewis, yeah. And they're consistently first or second in levels of customer satisfaction. They have 3 layers of hierarchy, and the role of the board, they say, is to support the partners, the front lines. Our role is to support the frontline staff to do what it is that they want to do, which is deliver great service. The second is these are organizations which have developed inclusive leadership and management styles across their organizations. Nottinghamshire Healthcare NHS Trust has a program called Invest to Lead, and they've trained 3,000 of their leaders in a positive, supportive, enabling approach to leadership. The third is that these are trusts that have put staff in charge of service change. Not only have they said, we give you the freedom to innovate, to make service change, but they've given them the skills. So they've developed the skills of innovation, of service improvement using things like Six Sigma or Lean or whatever it is. It doesn't seem to matter what the particular program of quality improvement is, but they have made sure that they've provided staff in a sustained way with the skills and the learning, and they've continued to provide them with that. So many of these organizations are working with the Institute of Healthcare Improvement in the States and investing to ensure that their staff are trained by IHI people. Or Wrightington, Wigan and Lee works with Unipart, which is a car parts distributor, to adapt their process improvement and lean techniques to use quality improvement at the front line. So they have teams of staff on the wards clustered around whiteboards 3 times a day to look at the data on how well they're performing so they can quickly adapt and improve and learn. And there are high levels of values and trust in senior leadership in these organizations. And it's really kind of important, what we know from the international literature on engagement is that trust is key. People have to trust their leaders and their managers. Because why would you take the risk of giving of yourself in that way unless you trusted the people who lead you? But what we see is that, and perceptions of unfairness are the most important detriment to levels of engagement in NHS organisations, and in particular, levels of discrimination. So, we've just, I think Simon Stevens is talking tomorrow about a report we've just produced for NHS England on levels of discrimination in the NHS. And you'll kind of be aware of the data around promotions to do with black and minority ethnic group staff. You're 3 times more likely to be promoted to a leadership position in the NHS if your skin is more similar to my skin colour than to someone who is from a black or minority ethnic group background. I mean, how bizarre and appalling is that? So when we've been looking at the levels of discrimination experienced by black and minority ethnic group staff from people of different religious backgrounds, you're 12 times more likely to be discriminated against if you're from a Muslim background. We've looked at gender, age, disability particularly. Those who are disabled within the NHS staff are incredibly highly likely to report being discriminated against. And if you work in ambulance trusts, it's particularly bad compared with other trusts. The levels of bullying and harassment within the NHS are remarkably high as well. It's something around 26% of people are reporting that they've been bullied or harassed by colleagues in the previous year. Even in the worst outside industries, the highest levels are about 16%. So, and we talked earlier about where some of that comes from. Some of that comes from, the way the system is operating as a whole, but it also comes from the way that leaders and managers are managing and the way that people are behaving with each other. Cultures of compassion. And I think this issue of discrimination is really hugely important because the NHS is about, those founding values are about we will provide compassionate care, high quality care for everybody. Doesn't matter who, what background you're from, what age you are, your gender, your ethnicity, your religion, inclusiveness and inclusion. And so that issue of creating cultures of inclusion and valuing diversity is really important. So what we know about diversity is that I was saying to you a little earlier that in teams, diversity is either a really good thing or a really bad thing. So teams that don't function very well, diversity seems to create more conflict. Whereas in teams that function well, diversity, whether it's ethnic diversity or professional diversity or gender diversity, seems to have really positive effects in terms of performance and in terms of innovation. So, and by functioning well, I mean teams with clear objectives, high levels of participation, supportive, positive, people listening to each other, real commitment to quality, but people valuing and respecting and supporting each other. So part of engagement it's fundamentally about inclusion. And it is a huge issue in the NHS, this issue of inclusion and dealing with the extraordinarily high levels of discrimination. And I think that the 6 characteristics that we're talking about here, in addition to the kind of HR interventions that we know need to be in place. But creating these kinds of cultures helps us deal with those problems. I'll come back to this issue in a moment. And it's about stable senior leadership. What's really interesting about these places is that the engagement seems to lead people to take responsibility for delivering high quality care. So I went to Wrightington, Wigan and Lee a year ago because I knew that they'd been doing really well with their levels of engagement. I went to their engagement committee meeting and they kept talking about the horse. I had no idea what they were talking about. I eventually asked the stupid question. And a patient was dying in the palliative care ward, cancer ward, and she was just a few hours from death and asked some of you will know this story, but it really moved me. So a nurse asked her, was there anything she could do for her? What would she really like? She said, I'd love to see the horse I raised. Bronwyn, who was 25 years old. So I'm not sure if I've got the slide, but what they did was they called the family and said, can you bring the horse in? And they got a horse box, brought the horse in, and wheeled the patient out on a trolley. She called the horse that heard her. It heard her, and somebody was leading it. It came over and nuzzled her, clearly recognized her, nuzzled her and kissed her. And it was just the most moving moment. It was captured by somebody on a phone and tweeted, and 5 million people have now seen this picture. But it was an example of somebody being committed to providing high quality, compassionate care and making a decision and not calling up, health and safety or going through a risk assessment, just did it. And I keep hearing stories from places where this level of autonomy and support and engagement and trust has been created, that people are free then to take those actions that are really motivating for staff, hugely appreciated by patients and service users and families. So I think these lessons are really important. If we want staff to treat patients with care and respect and dignity and compassion, we have to treat staff with care and respect and dignity and compassion. Listen with fascination, be empathic, take intelligent action to help them do their jobs more effectively. Find out what's getting in the way, remove the obstacles. That's our responsibility as leaders. And for me, I'm not going to spend too long on this, but fundamental to culture is how positive it is. Doctors make better medical diagnoses when they feel positive emotion. 3-year-olds produce more creative paintings when they feel positive, and they play more altruistically. Teams function better when they're positive, when there's positive emotion. So, if you take the top 10% of the population in terms of positive emotion and the bottom 10%, there's on average a 10-year longevity gap between them. Positive emotion is hugely important in human behavior. And if we want to enable people to deliver compassionate care, then we have to, as leaders, create positive environments. It doesn't mean that we go in being happy, clappy leaders, or in some sense. It means being authentic, being real, being open, wanting to learn as a leader how to be better, being kind as a leader, being kind to the people that we lead, and being appreciative. Being appreciative, putting your arm around people and saying, you're doing a great job here. Actually, appreciation, if we think we're doing enough of it, we need to do 10 times more, because it's the consistent complaint from staff in the NHS that they're not recognised and they're not appreciated and they're not valued. As leaders, we must be doing that all the time, authentically, openly, kindly, appreciatively. Because there's enough negativity in the NHS with death and pain and fear, lack of control, people feeling out of control, patients, that we don't need to add to it through punitive leadership styles and directive controlling leadership styles. And it's also about, by the way, really importantly, is dealing with the behavior of some senior staff that's intimidating, aggressive, inappropriate. I think if you have, let's say, a consultant medic who is an aggressive, intimidating individual, that is about the most dangerous circumstance you can have in an organization in terms of patient care, because people are afraid to challenge unsafe behavior. If I'm afraid of somebody and I see them doing something that I think is inappropriate in terms of patient care, I'm much less likely to say anything. So we have to, I think, challenge inappropriate behavior, especially at senior level, but throughout the organization. So it's not just about being warm and kind and supportive. I mean, in a sense, a deeper kind of compassion that we need to address issues to do with inappropriate, intimidating behaviors and poor performance. Make sense? How are you doing? So the fourth area is learning, quality improvement and innovation. And in the work that we did, the biggest deficit we found, I mean, I said dialogue was really missing. But what was really concerning was the low levels of innovation in NHS organizations. So we asked the 650 clinical teams, what innovations have you introduced in the last 12 months? We had more reports back, open comments back, telling us why they couldn't innovate than we did examples of innovation, and that's deeply concerning. When we looked at board meeting minutes and we tried to pull out examples of innovations boards were introducing, we found this is true. It was a really careful analysis. The average number of innovations introduced by boards during that 18-month period was between 1 and 2. So there's something about the way the system is operating that is pressing down on people and preventing them from innovating. But the only way we can continually improve care, we can deal with the challenges that face us, is to release the innovation that exists within the organization. I think, I can't think of any other industry that has the level of skill and the level of motivation amongst its staff that the NHS has. The level of motivation is incredible, despite the stress, despite the bullying, despite the discrimination. The level of motivation is huge, and the level of skill is incredible, and the shared vision about compassionate care. So what we have to do is create the conditions where people are able to develop new and improved ways of doing things and can make a difference. And we're doing a big project with the Health Foundation at the moment focused on that. And that's really about ensuring that people are empowered in the way that I described, for example, in relation to Wrightington, Wigan, and it's making sure that reflective practice is endemic, that people have the time to reflect, that errors are constantly used as a source of learning, or near misses are constantly used as a source of learning. Please.
I just wondered my thought on that was is it because people don't recognise that the changes that they make are innovations? Because I think there are low-level changes to procedures and to working practices, and the sort of all the time things are moving, and I think people don't always recognise that what they're doing is innovative, and that could be shared with other wards or departments or whatever, but they just kind of see it as trying to make their own lives easier or things work better on their ward. It's a bit of this silo work that you talked about earlier. I think there's probably more innovation happening than people recognise they're doing, if that makes sense.
Yeah, no, I'm sure that's right. We deliberately don't use the word innovation when we use in the questionnaires, because people think, oh, innovation, inventing the telescope or whatever. Yeah. And I'm sure there is a lot of granularity in the changes that people are making. But in general, we have the sense that the lack of autonomy, the extent of hierarchy, the creation of fear through punitive approaches to management all depress people's willingness to innovate, to take risks, even to have the time to have discussions about new and improved ways of doing things. So what's going on here with the collaboratives, I think, is enormously important. So there is something about the way that people are working, that they see innovation as being the job, as finding new and improved ways of doing things as being the job, and that they find that when they have an idea for how they can really, whether it's reducing something or improving something, that they know what to do with that, where to go, how they can get support. But that needs to be built in across the system. And it's one of the areas of focus that we're taking forward in conversations with Monitor and with CQC also, about how we can develop within NHS organisations people's autonomy and support to make the changes that they know need to be made, rather than feeling a kind of learned helplessness about not being able to make changes in the system.
I heard the other day that when organisations are under quite a lot of budgetary pressure, this can kind of squash innovation. I don't know if that's really true, because there are sort of lots of small improvements happening, but what's your view on that?
Budgetary pressure. Well, we've been looking, for example, at teams over the course of the last, a particular project on team working in healthcare over the course of the last 15 years, looking at the extent to which teams take time out on a regular basis to review what it is they're trying to achieve and how they're going about it. In particular, we published a study 3 years ago that focused on teams under pressure, either financial pressure or pressure because of the premises that they were in being inadequate, or pressure because of the number of patients that they were dealing with. And what we've found is that teams that take time out on a regular basis are much more productive and much more innovative than teams that don't. So budgetary pressure by itself will be a problem unless there is a way of working that enables teams to have the time to reflect on how they deal with those pressures. So where teams take time out on a regular basis, they're much more productive and much more innovative in the context of high levels of pressure. And that finding has been replicated in lots of other countries now as well, in the Netherlands and in Denmark, in Hong Kong, in Australia, in the United States. So there's a really clear finding. And it goes against that, what we see in the NHS of when the pressure's on, you just spin the wheel faster. Just spin the hamster wheel faster. No, you stop, step back. And we need leaders to endorse and support that taking time out to review. And actually the work, even things like after action reviews at the end of shifts or at the end of surgery, the data show that regularly having after-action reviews is associated with a 25% improvement in performance. 25%. Taking the time to review how we're doing, how we're working. Please.
You mentioned financial premises and patient pressures. I would add in regulatory pressures.
Yeah.
Because actually we're so busy spinning that hamster wheel, ticking the boxes for CQC, for whatever else the regulators say, that we don't have time.
Yeah, absolutely. Absolutely. So, any questions, comments? Why don't you have time? We've talked about two things particularly: people management, stress, engagement, compassion, positivity, supporting quality improvement and innovation. Same discussion around your tables for us as a collaborative, and or for our organisations, and or for the system that we're part of locally. Thank you. So forgive me again for interrupting your conversations. Forgive me. I'm sorry to interrupt your conversations. Because I promised you 2 more dimensions and we need to cover those. But before we do that, are there any thoughts you would like to share from your discussion with everybody in the room? Just put up your hand if there's something you'd like to share from your discussion, an observation, and I'll come running with a microphone.
We've really done a full...
I think it's switched on.
We've really done the full circle, if you like, because we started acknowledging the point that was made across on the other table about the huge impact that financial pressure has on real-world working, and that how we needed to engage in business management talk or learn the language to try and progress our agendas to make innovation happen. And we then sort of travelled the conversation through to consistency of leadership is really important to facilitate all of this and to get the right culture going within the organisation to progress it. But we're living in a society that sees success as promotion. So if you're successful, you're forever moving on to the next job. And then that went forward to, but we need to innovate, and to be innovative, we need to feel safe. And we need space and we need time to talk and discuss this and create the dialogue needed to create innovation, but that takes money. And we don't have the money. So we sort of did the full circle, and I suppose that really then makes me think that we need to work differently. And the answer is perhaps out there, but we need to think more radically, perhaps, about how we deliver care.
The bit I didn't understand was when you said that if we to create space for time to talk, we need money.
Yes. We talked about the pressures, particularly on ward teams, and the difference when you take a staff nurse out of a ward team to a different working environment, how they can really grow and develop. And that's just by investing a little bit of time and education in that person. But how do we create that for ward teams and nurses delivering, huge proportional care to very vulnerable patients? And that takes more ward staff, really, if you're going to give them time away from hands-on care delivery. But then where do we get the money? So no answers, lots of questions.
And it's clear that there is a huge problem in terms of finances within the National Health Service. There's a letter in yesterday's I think it was in the Telegraph yesterday, from Chris Ham, who's the Chief Executive of the King's Fund, Jennifer Dixon, the Chief Executive of the Health Foundation, and Nigel, the head of, Matthew will remember, the head of the Nuffield, Nigel Gone. It is definitely, no, all saying we need the 8 billion now. It's not manageable. And, you get what you pay for. And we're lower than most OECD countries now in what we're paying for in health. So it's clear there's an issue. The danger, it seems to me, is when the discourse becomes dominated by finances rather than dominated by care quality. Thank you very much. Other qualities? Sorry? Nigel Edwards, yeah. Thank you. Okay, well, forgive me. Let me move on, because I want to cover the last 2 points. Teamworking, we know, is really important for healthcare. So there's so many international studies that have shown the importance of teamworking. We know that teamwork matters in terms of reduced error rates, patient mortality, staff well-being, and we know that multidisciplinary teams deliver higher quality care and implement more new and improved ways of doing things. But it's also about how teams work together. I've mentioned that already. It's about looking at communities of teams. So when we think about organizations, we often think about hierarchies. But if we want to build team-based organizations, it's important to think about the communities of teams and how they work together. So, if you need really good collaboration between social workers and physio, then you need to ensure that those lines of communication about feedback to each other and shared objectives and shared vision are in place. So a lot of the work, one of the things we did from our research work in the 2003 was we set up a spin-out company from the university to take all our work on teamwork out into NHS organisations and work with NHS organisations to help them build team-based working. And we've got some outstanding examples of places like Mersey Care, Frimley Park, Birmingham Children's Hospital, lots of trusts that have done a lot of really good work around developing team-based working. So it is not just about building teams. And I'll show you the importance of team working here. This is based on the acute sector, as you can see. In the staff survey, people are asked, do you work in a team, yes or no? And around 91, 92% of people say they work in a team. And then we say, in the survey it says, does your team have clear shared objectives? Do you work closely together? Do you have to work closely together to achieve those objectives? Do you meet regularly to review your performance and how it can be improved? Because we think those are the basic criteria of team working. So when you use those criteria, the figure drops from 90-odd% to about 41%, which gives us about 50% of people working in what we would call pseudo or dysfunctional teams, about 40% in real teams, and then around 8 or 9% in who say they don't work in a team. Not sure what they do, but hey. Anyway, so this is an analysis of errors that could harm patients or staff, levels of stress, levels of injury. These are people working in real teams. These are people who say no to one of our criterion questions, no to 2, no to 3. This is a very small group who say they don't work in a team. And you can see that working in real teams is associated with significantly lower levels of errors, stress, and injury. And we think it's because when people are in pseudo teams, there's an assumption about what the shared objectives are, or there's an assumption about who's going to take responsibility for what task. So, I'm expecting you to check patients for bed sores. You expect your colleague will do it. He expects it's someone else, and it doesn't get done, and mistakes are made, and patients die. That's the reality that we know. And so team working, I think, is as important to patient safety and care quality as medication errors, dirty wards. It's really, I'll show you some data on, that's just showing how people working in real teams are significantly less stressed than people who work in pseudo teams or not in a team. This is some data on patient mortality. Looking at the staff survey data over time, we can see that 5% more staff working in real teams is associated with a 3.8% drop in patient mortality, which is, for the average acute, about 40 deaths a year. Those figures might not seem large, but if we could change, given that we think 50% of staff are working in pseudo teams, if we could change that to 25% across the system, that would be 30,000 deaths a year. Real teams are people who say they work in a team and they say that team has clear shared objectives, that they have to work closely together to achieve the objectives, and that they meet regularly to review their performance and how to improve it. So, these effects are enormous, and it's enormously important that we improve the quality of team working, even around those basic issues to do with shared objectives and meeting regularly to review performance. I gave you the example of after-action reviews in teams, 25% more effective if we have after-action reviews. 25%. And this is not a single study. This is based on all of the studies that have looked at after-action reviews. An effect size of 25%, absolutely enormous. So it's about, in terms of team leadership, making sure the team has an inspiring vision and clear direction, ensuring that people are meeting together and having dialogue, and that those meetings are positive rather than, yawning. At the end of every meeting, we should be going around everybody and saying, how was that meeting on a scale of 1 to 10? What could we have improved? What went well? Every meeting, because so much time is spent in meetings, and they should be fun, they should be engaging, they should be enjoyable. But we waste so much time. Encouraging positive, supportive relationships. Interpersonal conflict in teams is a disaster. Chronic interpersonal conflict is a disaster. There's no two ways about it. If you've got two people who don't get on, it's a major problem in terms of, and if it's a front clinical team, it's a major problem in terms of patient care. So we as leaders must get people to resolve conflicts or adopt a professional attitude which says, I may not like you or want to go and have dinner with you on a Wednesday night, but we work professionally in a team together, and it's about patient care. And it's about positive group attitudes towards diversity. It is in teams that discrimination is most likely to manifest, apart from promotions, but the day-to-day texture of people's experiences in teams. And if we can create positive team working, where diversity, difference of opinion, difference of background is seen as being the valuable characteristic that it is, then those teams are much more effective and people are much happier and well-being is much higher. As I say, this report is coming out tomorrow. And I do recommend that you have a look at it. And it's about leaders, paying attention, listening with fascination to the team and leading into team cooperation and so on. So the last point I want to make is the importance of leadership, of the kind of leadership that we have. Matthew, will you shout at me when I reach 1 o'clock? So the evidence we have is that we need to move away from leadership being about people in authority in healthcare. It's about, and it's not about heroic leaders who, inspire us all. It's about leadership being a collective activity where everyone takes responsibility for safe, high quality, compassionate care. And it's about ensuring that leaders at every level promote engagement and participation and staff autonomy and accountability, that everyone's heard, that everyone is enabled to be proactive, responsible, innovative, that they can make a difference rather than feeling this learned helplessness that comes from too much hierarchy, too much bureaucracy, too much regulation, as you say. And avoiding domination and command and control, except in real crisis. Dealing effectively with intimidating behaviour and poor performance that we've talked about. So King's Fund and the Centre for Creative Leadership have published a couple of papers on this that describes the work that we are pursuing. Let me explain. What we want to do is achieve, what the evidence tells us is we need to have collective leadership where everyone sees that they have leadership responsibility, that there are times when I need to speak up, there are times when I need to intervene. That's the nature of this organisation. Everyone knows that they can be a leader at any point in the day. Second, that there's shared leadership in teams. We know that shared leadership in teams, it's where Pam, if you're the hierarchical leader, it makes no difference if there's an issue that comes along where your colleague Lynn has more expertise or motivation, the leadership seamlessly kind of shifts. It's just, you may be the hierarchical leader, but actually the leadership is invested in you at those times, quite naturally, because that's the best way of operating. And we know that whether it's in healthcare or any other sector, that's what is associated with high quality and effective and productive and innovative team working. And it's about interdependent collaborative leadership, where leaders are working together across the system to prioritize quality of care rather than just their own individual area, so that we're saying how can, it's not handing off or having, as you describe, multiple referrals all of the time. It's saying we all take collective responsibility across boundaries for delivering high quality care. And it's about having a consistent approach to leadership, where instead of having some bullies and some enlightened leaders, we've got a consistent approach across the organization. How do we do that? Sounds good, but how do we do it? What we've seen across the NHS is almost every organization we go to, interim people in post, vacant posts, the percentage of chief executive posts that are vacant, finance director posts, clinical director posts, and on and on and on. All of these vacancies, all of this interim reactive ways of dealing with leadership. Leadership is the most important influence on culture. And if we have a make, do and mend, temporary, intermittent, reactive approach to leadership, we get the leadership that we've planned for. And that actually what we have to do is ensure we've got the leadership in place now and in the future that we need. So that means that we need to have a leadership strategy, forgive me, but we have to plan to get the leadership in place that we need for the cultures that we want. If we want leadership that is continually improving, high quality and compassionate, we have to plan for that, and we have to take action to have that leadership in place. So what we are doing is working with individual trusts at the moment to get those strategies in place. We've just started working with Monitor to develop a set of supports for trusts so that they can, first of all, assess their own cultures, assess their own leadership, which will include things like how managers and clinicians are working together, to pick up that point, which will include things like the extent to which there is discrimination against various groups in terms of leadership, the extent to which there's discrimination within the organisation generally, and to look at the extent to which they have the leaders that they need in place and what leaders they need for the future in order that we can design a strategy which will deliver leaders, which will have appropriate representation of, for example, black and minority ethnic group staff across the system, and where you have appropriate leadership by clinicians across the organisation, and where you have, and this is really critical, a pipeline of leaders ready to step into leadership positions when people do move. But actually, it's about creating the cultures where people are reluctant to move because it's such a good place to work. So it's building a pipeline of leaders, having, if you like, bench strength. You've got the leaders on the field, but you need bench strength. So when a vacancy happens or someone gets sick or someone moves on, that you've got people ready to step into those positions. And I'm struck by the comparison with the military. You know, the military, when they think about, it's a life and death business, their leadership is thought through for years ahead. It's planned for years ahead. In healthcare, we operate a make, do and mend approach to leadership. So as a consequence, cultures are not the way they need to be. So the work we're doing with Monitor is about developing a set of tools and processes and supports to help organizations go through these steps of looking at their existing cultures and their leadership and designing an approach to ensuring they have the leadership in place and then implementing that. And that's about, you know, that's a big program of integrating HR practices and organizational development and leadership development, but ensuring also it's leadership, it's evidence-based. So, excuse me, the sixth point is about, it kind of in a sense complements the point about building effective team working. The sixth point is about ensuring we've got collective leadership in place rather than dominant hierarchical leadership. We completed a review of climates and cultures of healthcare excellence, all of the research on that over the last 50, 60 years. It was published last year. And again, I can send it to you. And that concluded that dominant, top-down, hierarchical approaches to leadership in healthcare was about the worst kind of culture you can have in terms of healthcare excellence. So it's about how we get those sorts of leadership cultures in place. And we've got various tools that we've developed, which includes analysing culture, along the dimensions that we've talked about, and includes looking at the key leadership positions within the organisation, the leadership pipeline and succession planning, and so on, and identifying what the key leadership behaviours are that we need in organisations. I'm kind of running through, but all of these things are available from these downloads. And we're adding to this the notion of compassion. So I'm going to stop because I think we have reached 1 o'clock. But just to say, this is where I was last week on Arran. It didn't look like that at all, but it was wonderful. We've run out of time. I'm going to hang around for a while to have conversations if you'd like to have conversations. I think the last thing I want to say is compassion begins with you. That actually, in order to create compassionate cultures, that you as leaders need to be compassionate. But to be compassionate, you need to be compassionate first towards yourselves. So it's really important that we as leaders pay attention to ourselves, listen with fascination, have an empathic response, and take intelligent action to help ourselves. Because in order to be compassionate, we first have to understand the importance of having compassion towards self. It's a challenging concept, but I think it's really fundamental in terms of our understanding of creating cultures of compassion. So it's about caring for ourselves. And the last thing I want to say is just a huge thank you to you for the privilege of being able to talk with you, talk at you, listen to you, engage with you. And thank you. Yeah, thank you very much.